Welcome to the Centre for Global Development event, where we're asking today, will Canada be a global health champion? My name is Pete. I'm the Deputy Director of the Global Health Programme here at CGD. This event comes as global health is in a crisis, with expected cuts of up to 40% of aid from a range of G7 global health donors. In contrast, voters in Canada have elected a party pledging to protect Canada's proud tradition of supporting the poorest and most vulnerable. So I think we all turn with some cautious hope towards Canada as a potential future leader in global health. Thus, it's very timely that the Canadian Academy of Health Sciences and the Royal Society of Canada released its report this year titled Protecting Our Collective Future, Renewing Canada's Role in Global Health. Today, we have an eminent panel to discuss the report's findings, and this includes Professor Kelly Lee from Simon Fraser University, who was a co-chair of the report's panel. She will begin with an overview, and then I'll introduce the three panelists as they come online. So firstly, over to you, Kelly. Delighted to have you on board, and thank you for your 8-minute introduction.
Thank you so much, Pete, for the invitation to present. Looking forward to the conversation. All right, let me just pop these slides up. I thought I'd done that. Doesn't seem to be working. There we go. Thank you. So as Pete said, my name is Kelly Lee. I'm a professor here at Simon Fraser University. And before I start, I wanted to just acknowledge the unceded and traditional territories of the Coast Salish peoples, including the Squamish, Tsleil-Waututh, and Musqueam nations, where our campuses are privileged to be located. So our joint panel was commissioned by the RSC and the Canadian Academy of Health Sciences. We were led by Professor William Galley from the University of Calgary, and we were given the mandate to review Canada's past, present, and future role in global health, and also to provide some insights and recommendations that can inform our country's future strategy over the next 20 years or so. I was joined by Tim Evans as co-chair and an excellent group of panel members, as you can see listed here, including Robert Greenhill, who is joining us today. We also had a wonderful secretariat led by Prativa Baral, who is also with us for this webinar, and 3 outstanding PhD students who are, some of who are finished now or are completed their doctorates. And so we had a lot of help doing this work. The context was that 2 years ago, we were commissioned to do this report, and we were still are in a poly crisis. So we have many things that we are battling in terms of policy challenges happening simultaneously, including the pandemic, but also many geopolitical shifts, instability in the financial system, climate change, and so on. So this diagram just seems to show the interconnectedness of these various crises. We also were coming out of the pandemic, of course, and there's no shortage of reports that were trying to draw lessons from the pandemic, how we could do better, what we did right, and those lessons continue. So what the panel was tasked to do was answer 3 broad questions. First of all, how can we characterize Canada's role in global health since the late 20th century? What lessons can we learn from the COVID-19 pandemic? And then how can Canada strategically enhance its future participation in global health over the next 20 years? And we conducted our work largely around these 3 questions. So I won't go into the methodology because we have limited time, but we gathered a lot of information through interviews, focus groups, available reports, primary and secondary sources, and so on. And I thank the Secretariat for doing that heavy lifting. And from that, we can look at how we can characterize Canada's role in particular since the late 20th century around global health. And what we found and what we heard was that there were many positives. We heard many times the celebration of the IDRC, International Development Research Center, which is somewhat unique in that it supports researchers in low and middle income countries to lead research projects. One in particular was the IDRC Micronutrient Initiative, which was initiated in the mid-1990s, and that's still going strong, having been catalyzed to create the Scaling Up Nutrition Movement and the Nutrition International efforts. And so that's one example of how the IDRC has seeded efforts that have then become sustained activities. Canada has also been a very strong supporter of multilateralism historically, and it's one of the major funders of the UN system, with funding to WHO, UNFPA, Global Fund, etc. And that continues as well. Canada was also an initiator of many UN initiatives, such as the Ottawa Charter, and then many commissions, an active supporter and participant in the Framework Convention on Tobacco Control negotiations, and so on. More recently, Canada has been praised for being a leading funder of sexual and reproductive health and rights. And you can see listed here a number of initiatives that have led to major funding for this area of work, funding that is now under attack, as we know, and hopefully Canada will continue to champion this incredibly important area. And then finally, I must give mention to the Grand Challenges Canada, which has been going for, I guess, 15, 20 years now, almost. And it's funded initiatives over the years focused on innovations to address global health and development problems. It hasn't been all positive that we heard. We heard some negatives that we need to acknowledge. First of all, that Canada continues and still not achieved reconciliation commitments and obligations to the health and well-being of Indigenous peoples in Canada. And we could probably extend that to Indigenous peoples around the world. So there's still a lot more work to be done. There also seems to be still a prevalence in perspective on what we might call Global Health 1.0, which is seeing global health as largely development aid, as charity, rather than as an investment that serves all health around the world. And that still persists as a framing of what global health is. As such, there's not sufficient recognition of planetary and global One Health perspectives in global health. And this has led to, I guess, a lack of holistic approach. And there's a number of issues I'll come back to on why that is needed, a more holistic approach to global health. And then finally, we've heard comments that Canada has punched below its weight in terms of diplomacy in the last decade. And while Canada continues to be a major funder of global health, perhaps the normative leadership that we've seen in the past has waned. We saw disappointment in equitable access to vaccines during COVID and intellectual property rights. And there was comment around the rotating nature of the civil service within government in global health, which led to a decline in perhaps sustained content expertise. And this diminished Canada's capacity to participate more actively. We looked at COVID-19 in particular and drew some lessons, again, similarly to what I've just said, and I'll just go quickly. A strong supporter of multilateral cooperation. A lot of funding went to the global effort to fight the pandemic, for example, at the ACT Accelerator. But at the same time, you had perhaps more national-focused efforts, contradicting these multilateral efforts. So, for example, when the Omicron variant was identified, Canada was among the countries that adopted punishing travel restrictions on a number of African countries. The vaccine equity issue continues to be a major point of criticism of Canada during this time as well. And so just moving quickly to how we saw Canada strategically could enhance its future participation in global health. What we did is we identified a number of priorities. But before I just get to those, I wanted to say that in our deliberations, we had to think about a number of strategic considerations. And I should mention first and foremost that this was a deliberative process. This was not a research study as one might expect perhaps, or in the time we had available, what it was is bringing a number of key and highly experienced individuals together with the available data and information that we had and consultations to bring together what we can give as our best advice. So it's not a research study in strict sense. We also needed to be aware of the current debates around global health, and these are ongoing around the decolonization of global health, and trying to think about this in relation to research policy and practice. Most importantly, I think we needed to take account of the current and evolving domestic and global context. And we know that in the 2 years since we started this exercise, it's become a much more fraught and difficult environment. But what we're seeing is a lot of polarization in views, rise of nationalism again, a decline in public trust in government, big business, and the wealthy, as the Edelman Trust barometer has shown, for example. And so we needed to take this into account. And what we needed to do as a result is really balance our critical analysis with trying to advance engagement by Canadians and others in global health. So we couldn't just say what was wrong and then not balance that with, why it is still important to be engaged in this area. And so wanted to make sure that we focused on things that would engage people in this context. And that required particularly focusing on issues that link global and domestic needs, and to focus on Canada's particular strengths, and no country can do everything. And so we needed to identify that. So I just wanted to say that, and maybe the panel can pick up on some of those strategic considerations. We also wanted to land on a very clear definition of global health, and we did so trying to get away from the Global Health 1.0 by thinking of global health as an interconnected area of research, policy, and practice, which concerns the physical, mental, social, and ecological well-being of individuals, communities, and populations around the world. It emphasized the intricate relationships between people and all life on this planet. So we took a planetary approach, and we wanted to make sure that equity and social justice is championed in our definition. And so this is my almost final slide, just to summarize some of our key findings. What we did was we put forward 7 key findings and recommendations. We divided them into what Canada should do, so the more sort of content areas, and then how Canada should take these things forward. So we again identified areas where there was a shared interest in global and domestic health, starting with universal health coverage and focus on women in primary care. This is an area that all countries can benefit from, and mutually so. We talked about health security, of course, with pandemics, but at the same time, we recognize that how we approached the pandemic for COVID-19 was often from a national perspective. So we very much support a One Health Security concept, which focuses on sustainability, equity, and the universality of fighting pandemics effectively. We return to health promotion and protection as something that Canada has championed in the past. And then finally, we put forward some recommendations around health workforce crisis, which is something that many, many countries around the world are struggling with, and that Canada, at how it deals with that issue, needs to be placed within a global perspective. And that means not poaching other health workers from other countries, but really countries coming together and addressing this problem collectively. And then finally, we put forward 3 ways how Canada can take these priorities forward: a clear global health strategy led by a global health ambassador, strengthening our research and innovation systems, and then training our next generation of leaders in global health. We define pathways to do that. So I'm going to just stop there and hand it back to Pete. But if anyone wants to read the executive summary, here's the QR code for that. And there's the full report also available on that website. Thank you.
Fantastic. Thanks, Kelly. And hopefully Shannon or Catherine, if we can post the link to that to online viewers so people have access to it. Wonderful. Okay, so now to our panelists. I'd like to invite Robert Greenhill first as the Executive Chair of Global Canada and previously the President of the Canadian International Development Agency and also a member of this panel. Robert, would you like to offer perhaps some reflections first looking backwards at kind of how you see Canada's strengths and weaknesses historically in global health, kind of building on what we heard from Kelly?
Well, I think Kelly did a fine summary of where we've come from, as well as some of the tensions and therefore the opportunities going forward. Certainly, one of the key elements that came out very clearly is how do we link our domestic history and its challenges with what we're also doing internationally. So I'll give you one very real example, which was we had a lot of discussion on the health workforce issue in Canada because the concern that Canada was poaching workers from key developing countries who had their own health human resource shortages in order to meet our own domestic needs was a real contradiction. We were providing money to support development there, and then we are actually taking back, in terms of the poaching, a workforce that had hundreds of millions of dollars spent on their education and development in those countries. So this is the kind of area where with a net zero poaching approach, we're really trying to link how we are being more consistent in our domestic and our international engagement. One of the other items I would just underline is how many of the recommendations which were important when they were first put forward are now critical, given what's been happening with the cuts, particularly to the health systems internationally. And so Canada's redoubling its support for international health, and also ensuring that that support is focused on the most vulnerable and the most at need is perhaps even more relevant now than it was when the report was first produced. Let me stop there for now.
Fantastic, Robert. Thank you. I just wonder if you might want to say a bit more about the net zero migration idea. I guess, so CGD's done a lot of work on this space and we've tried to promote the idea that you can have positive win-win options here where agencies will provide a partnership with a medical school to expand doctors and training, as well as then acknowledging that some of those will come to a high income country in the long term, but the kind of win-win options. Is that a model in there, or is this more of a different approach?
So I think it was so the term we try to use is net zero poaching.
Okay.
So it may be that there is a movement, but it should be understood, properly financed, and supported.
Okay. Yes.
I think within our task force, there were different views. I would be more strict in terms of what I would think is what is appropriate. Others would be more along the lines of what you're suggesting, which is saying, well, if we're building capacity in those areas, and if in some countries actually have it as being almost a service or a human export because they've built it in to meet both domestic needs and international needs, well, perhaps that's an alternative. One of the things we said is we need to be much more explicit and honest.
Yes.
And thoughtful about what we're doing and what the knock-on implications may be. But let me turn it over to the other panel members if they wanted to add on that.
Prativa or Kelly, anything particularly on that? No. Okay, so the next panelist is Prativa Baral, Assistant Professor, Department of Global and Public Health at McGill University. So it's really the same question to you, Prativa. Thinking about the report and your own perspective, what and still looking backwards, really, what do you see as the kind of strengths and weaknesses that you'd like to highlight in Canada's historic contribution to global health?
Yeah, so I think Robert and Kelly did a fabulous job at talking about some of the strengths and weaknesses. But I think I would like to approach this framing a little bit from an early career perspective. So as part of the report's process, we spoke with a lot of early career practitioners, early career folks who are working in global health. And I think one piece that I'd like to stress that came up over and over again is really that point that Kelly made during her presentation how we often see global health characterized as charity, or rather mischaracterized as charity. And I think what we'd like to say and stress with this report is that this framing is not only outdated, but it's quite dangerous, right? We all stand to benefit from a more stable world, and global health is not about generosity. It really is about our shared survival, as cheesy as that sounds. And I think, in light of COVID, in light of climate disasters that we're seeing, and health inequities, all of these things don't stop at our borders. So at the end of the day, if we don't invest in global health, it is disruptive, not just from a health angle, but also from a supply chains angle. These strain global markets, as we saw with COVID, and they create ripple effects that, of course, disproportionately affect communities around the world, but reach everyone, including folks in Canada. So both from a historical perspective and from a forward-looking perspective, I think it is absolutely silly to think that we can take an isolationist approach out of this. We're talking about cross-border threats, and that we've made that clear in the report as well. So yes, there is a solidarity component, and there should be a solidarity component to it. But I think if we're all being pragmatic, as those of us in this panel and those of us tuning in are, what we saw during COVID is that solidarity only goes so far. So even if we take a purely self-interested lens, as many governments do and did during COVID, I think it still makes sense to invest in global health, and not out of pity, not out of charity, but because of our global stability depends on it. And so as Kelly mentioned, and as Robert mentioned, and as the report mentioned, one point that we really tried to stress is to move away from the binary local versus global to this more planetary approach to global health. The other thing that I'm reflecting on quite a bit is also a question that I think we're all asking ourselves, which is, what does success look like in global health? And I think we, as a field, we're still trying to figure out what that is. And I think part of understanding success requires that we define what we mean by global health in the first place. And the definition that is presented in the report and that Kelly presented shows that broader definition where we're talking about shared interests, shared threats. But beyond definition, I think, to me, success in global health, especially in light of everything that's happening right now and in the last few months, means a shift in power and decision making, in transitioning from donor-dominated models to ones that are led by countries and communities themselves. So there's a lot for Canada. There's a lot that Canada has done in this space, but there's still a lot more that Canada can do to really push for that newer version of global health. And what does that look like in an applied sense, particularly in light of everything that's happening? So there's a real opportunity, I think, for Canada to do this well, to not necessarily lead per se, but to model a different way of global health, given our history and given where we are. And I'll stop here for now.
Thanks, Pratima. That's great stuff. Kelly, I just wonder if you'd like to add to that point on going beyond aid and thinking about a more justice or investment perspective. Like you'd emailed about it before this meeting about how we should think more broadly about global health, and you've laid out that kind of nice definition of global health. But perhaps a bit more about your thinking on that and what the implications are for Canada in the future.
Absolutely. Thank you for that. Excellent comments by panelists. This is really core to how we see ourselves in the world, how we find solidarity. Is we need to really move away from that. I'm doing research in this country, and therefore I'm a global health researcher. Not necessarily. You're doing research in another country. That's not necessarily a global perspective. And I think that's just something so baked into our funding models, our the donor way of thinking, and it really misses that perspective of this is an investment in our own interest, but also that we are all sharing this planet together. And it's a very hard sell these days, as we know, especially since the report was, we started working on this report. The world has really shifted in very worrying ways. And it's tempting to focus on defense and economic policy, which is what's happening at the moment. And we've seen the G7 meet recently with very little, if any, talk of global health, which is for the first time in decades that's happened. Incredibly concerning. It's fallen off the agenda all of a sudden. And so we have this tendency to think that global health is somehow secondary, that it's if we can afford it, we'll invest in it. And this is what happens when we focus on health as charity, as aid, instead of as an investment. And we've just gone through a pandemic, as we all know, where this is probably the best lesson we could have, that our health is interconnected. I would say that for Canada, in this space, it's really tempting, and I understand why the country, you know, with its elbows up movement, is investing in defense and investing in a single economy. This is the priority of the government right now, and there's a temptation to almost try and swim with the big boys in terms of hard power. But Canada's history is really about soft power. It's about really doing the things that are normatively provide leadership, to initiate efforts that are really about supporting the multilateral system, being the honest broker, being the diplomatic facilitator of international agreements. It's not about hard power. Canada is not a big country. We're middle power at best. And we need to really recognize that in this kind of rush to strengthen our defense and strengthen our economy, that we have to also remember one of our strengths is global health. And so I'm very much hoping that we can take that route, that we see it as an investment in our own country, but also in the world, that we really very much need to participate as good citizens. And I would encourage other countries, of course, to see this as well. So global health 2.0 or 3.0, I don't know what version we can call it, but yes, and this is also part of the decolonization debate as well, which I'd love to hear from the listeners, the viewers today, about how they feel about that. So yeah, I'll stop there.
Thanks, Kelly. Robert, any reflections on that? I'm thinking particularly around, is there anything uniquely about Canada, like in terms of voters or politics or history, that makes it well positioned to support that change in agenda for global health, just global health 2.0, decolonization, these kind of issues?
Well, I think a couple of elements maybe help. Maybe one is because we're going through our own internal debate and dialectic about our own history of dealing with our domestic colonial heritage. Actually, in a sense, provides us with a sensitivity, which we had in our task force and debate on how does that position us internationally in terms of being sensitive to this issue. I think we also have in Canada, global health is one of the areas where there's been actually cross-partisan consensus for the last 15 or 20 years. So unlike other countries where there might be more partisan divides, in terms of continuing to focus on vaccine and dealing with infectious diseases, particularly with this government continuing to support maternal, newborn, and child health, but also the sexual reproductive health and rights, which are so critical and so under attack. I think there's an opportunity for us to continue to, and I like the way it was put to model, not necessarily to lead, but to model the right approach. One other item that was raised as a new area where we could link the local or domestic and the global was in calling for a task force to deal with toxic drug issues and the challenges of fentanyl and other toxic drugs that are having a devastating effect on our communities across Canada, but also around the world, and also fostering international illicit drug flows and other destabilizing elements. That would be an example where Canada could help lead on a global conversation on something where the local and the global come together. So I think our task force came away with a real sense that this is an area where Canada could continue to lead in, and if the government chose to do so, is likely to be able to do so with considerable domestic support.
That's great to hear, and particularly coming from the UK, where our kind of bipartisan support has collapsed. It's nice to hear that that's not universal. Prativa, I'm keen for you to build on some of the topics you raised around decolonisation. What options do you see for Canada to do that, to take a more decolonised approach, to take an approach that's more empowering of LMIC governments and citizens?
Big question, Pete. Yeah. I think just based on, again, all of the consultations that we did, I think it was really interesting to see the comfort, but also the discomfort that some folks had with the term decolonizing from the outset. And I think that's kind of the point, right? There is a level of discomfort here that we need to grapple with, given how the field was created, given the way that we practice still to this day, given the way that our institutions are shaped to this day. But I think the term decolonizing global health can feel abstract or even overused. Because again, we haven't really taken, or at least not all of us have taken the time to really understand what that means. But I think at its core, it really is about a lot of the topics that we've talked about today and that we described in the report. It's a reckoning with the power imbalances that we're seeing that kind of shape our knowledge, our funding, and decision-making, and the flow of these in the field. And so some of the questions that I think we need to start with when we think about decolonizing are basic, but also are incredibly powerful, like who sets the agenda? Who gets funded and who decides how that funding flows? We can even go further and think about whose expertise is valued, what knowledge systems are we valuing, and whose knowledge systems and expertise are we excluding. So I think it requires all of us individually, those of us who work in this space, but also the institutions that work in the space, to kind of look inward and assess how we might be perpetually or accidentally furthering this agenda, and how we can reckon with a new form of global health architecture where those imbalances are not as vivid. I also think we need to be honest about how easily decolonization becomes symbolic. It's used in project titles, it's used in mission statements, and I think we really need to think about what does that mean when we're talking about shifts in practice. So some of the examples that we heard during our consultations, and that I've been thinking about with some of my other peers as well, when we think about redistributing of power, does this mean letting lower and middle income country partners set the research agendas, lead grants, co-lead grants, rather than just being on the implementation side? Does this mean funding, indigenous ways of knowledge, non-English knowledge systems, non-Western knowledge systems? Does this mean training Canadians and others, researchers, in things that should be basic but aren't necessarily always at the same baseline everywhere? Things like structural analysis, power dynamics, cultural humility, governance. Does this mean valuing experiential and local expertise as much as credentials and large institutions? And something that I think we've been thinking about a lot, and that's made it in the mainstream, so to speak, is the whole issue of visa systems, right? Who gets to attend these conferences, who gets to speak in those conferences, and who doesn't, because of these larger structural issues. So I think at the end of the day, decolonizing global health, it doesn't just mean shifting where the work happens, but it also means changing how we work and who gets to lead. And I think Canada can do a lot here in order to push for that difference, modeling behavior and leading differently.
Fantastic. I'd like to turn now to more the global health architecture. And here I'd like to go first to Kelly. You'll probably be known by some of the audience for your research on global governance, global health governance. We did hope to have Mercy on the panel, who co-chaired something called the Future of Global Health Initiatives report, which produced a final outcome document called the Lusaka Agenda, which talks about some things in line with your report about moving to primary healthcare approaches, empowering local citizens, and so on. I wonder how you see Canada either supporting those reforms or anyway, over to you. How do you see Canada being a valuable contributor to global health governance?
Yeah, I very much see Canada as part of that. The country's always been an active participant in these discussions, and they're as important as ever. I mean, there are very familiar challenges that Prativa just described about donor, dominated decision making, about the kind of sharing of power, the way that the global health architecture is being formed is pretty much a laissez-faire, donor-driven process. So we have a patchwork of institutions. We don't have a coherent strategic vision of what global health governance needs to look like. It evolved over time. Some donors wanted to deal with these diseases, and so initiatives were created over time, but other diseases were neglected and so on. So we kind of know that familiar set of challenges that we face, and we somehow stumble along and stumbled through the pandemic with WHO underfunded, with lack of authority, and then blamed for not doing the job we imagined it should do, even though we hadn't supported the organization. And here we are now in an even dire situation. So WHO is being pummeled with the withdrawal of the US and all sorts of things going on. I do see this moment, though, as an incredible opportunity. So I know that there are initiatives underway. I'm involved in one of them with the Wellcome Trust, looking at trying to find ways to think about transforming the system. And this is the moment that we have had a shock to the system. We've had, 30-40% of global health funding suddenly disappear. And this is going to force countries to reflect very hard and very fast on what to do. And you're already seeing some countries step up. You're seeing some real real reflection on what is essential for us to do. How do we do this better, and so on. So there's certainly a movement involved. I think underway to think about these really core issues. There's nothing like that necessity is the mother of invention. I think that's very much describing the situation now. So I don't have easy answers. I do know that these are long-standing issues. I think for now, I think what we first have to recognize is that there's a lot of public distrust out there in terms of public institutions, governments, and that this is reflected in the criticisms of WHO. There's partly it's a lack of understanding of what the architecture is and what it is able to do, given member states' willingness to share sovereignty and empower these institutions. But partly it's a disengagement. There's a lack of, I guess, feeling that these institutions are serving the needs of people. And we're seeing this across the political spectrum, both left, right, and center, I guess, even in the middle. And so these institutions aren't fit for purpose in the way we need them for the 21st century. And so I'm trying to think big on what we need. There are technologies that can improve the democratic process, for example. How can we harness digital democracy in ways that citizens can feel more part of how they're governed? And how can we achieve this at the global level? How do we share power in a way that actually makes people feel like they have a voice? Our representation, yes, we have 193, 94 countries represented in WHO, but is that really representing the global citizenry? When we have, the World Health Assembly with ministers of health discussing for a week once a year, it's not a great way of representing the voices of people. And so we got to rethink how we do that, make it more engaging, make it more accountable, transparent, and so on. There's lots of ways I can go on, but I think that this is a moment really to think big. Like this, after the Second World War, we created WHO. I think this is almost in a sort of similar crisis situation where we really need to think again and go back to the drawing board on the global health architecture.
Thanks, Kate. Big thoughts. But I wonder, Robert, if I'm getting questions from the audience more focusing on the aid side of the multilateral system here. So asking about, we've got a Gavi replenishment expected I think tomorrow is the main summit. We have a global fund replenishment towards the end of the year. We've obviously got the World Bank IDA replenishment that happened previously. Do you have any recommendations on how Canada could I guess my worry is that they will receive limited lower pledges and will be forced to make very dramatic changes rather than the calmly planned reforms for the next phase of global health, in line with, I guess, what Kelly was saying. So how do we get those institutions, or how can Canada contribute to getting those institutions to a more positive place? What role can Canada play in helping those organizations reform towards some of the themes that we've raised today?
Well, this is probably beyond the actual recommendations of our report and the how to, but I think it is showing a real sort of commitment to the principles of achieving global health for all, but then kind of a tough love in how we do it. I think the question, so Gavi and the Global Fund have existed now for over 2 decades. How many more decades should they be existing? Or if it really is about building capacity, at what point are we really building healthcare systems such that there can be a withering away of Gavi and the Global Fund? So these are 2 examples of where Canada has been a real leader from the beginning and should be very supportive of the replenishments, but also should be demanding of what is the end game and what is the vision we can communicate to our own taxpayers as well as citizens around the world as to where this is going to end up. And I think that's part of the challenge right now. People are feeling that we're spending increasing amounts of money going into these things. And as Kelly said, without the trust that people say, well, it's fine. We're sure this money is being well spent. I think now's the opportunity to say, where are we going with this? And how will we get there? And what is the structures we need to get there? Because Gavi and Global Fund were an example of 20 years ago, adding on new structures because we were dissatisfied with existing structures, but we didn't eliminate any of the existing structures. There's probably an opportunity for massive consolidation, concentration, and collaboration to ensure that every dollar spent, every human resource deployed here is really achieving the maximum that it can for the people who are supposed to be helped in the healthcare system. That's a huge challenge and a huge opportunity, and it requires governments doing it, starting with Canada, to do it with tremendous goodwill and commitment to the end game, and not doing it just to cut funds. Which is why if the Carney government chooses to, it could be particularly credible in modeling this, because it has made it clear it's going to try to maintain its commitment to development while increasing its commitment in defense and other areas, and not see them as a direct trade-off as the UK government has recently done. Now, one thing I should note, this is hope for what the Carney government will do, because they've only been in power for under 100 days. We don't yet know what is their level of strategic and financial commitment to this space. This still remains to be seen.
Well, hopefully this event will encourage them to be ambitious. But more seriously, I guess the challenge is how they make that multilateral reform collaboratively with other countries. I think one of the problems right now is there's no kind of coherent vision. There's no mechanism even for countries to come together behind a single vision, which means all the reform agendas are pretty chaotic. I think someone, whether it's Canada or the UK, needs to show some leadership here and try to bring the right people together. Well, maybe it's a good question then, Prativa. How could that happen? How would Canada be involved in that leadership, but in a way that's empowering? Because the risk is that the G7 nations come together and sew up a revised future of global health by themselves. Is there a way to do that in a more constructive and decolonized way, I guess?
And I think you're asking, how can we reform the global health architecture so that it's successful? I mean, I think one piece of all of this, you named it, right? It's the coordination piece. Even within Canada, some of the consultations that we did showcase that right now the current system within Canada, but also globally, is quite fragmented, could be duplicative, siloed. Someone mentioned that Canada is the land of pilot projects, for example, but I think this is not a problem that's unique to Canada. This is something that I think global health as a whole, in terms of its architecture, has been kind of guilty of. So I think it goes back to what you were saying, is just we need, you can have all of the science, you can have all of the data, you can have all of the money in the world, but if you do not have the right leadership and the right coordination mechanisms in order to make sure that our agendas are collated, are coordinated, and that we know, precisely to Robert's point earlier about what the end game is, what success looks like in this field, then I think it'll be an ongoing challenge. So in terms of Canada's role, I think there is a lot that it can do and has done in the past, and can continue to do so. I think it was Kelly that mentioned the soft power piece that Canada holds. And I think the convening power that Canada holds is something that we don't think of as in a focused way as we do with the dollar amounts. But there's a lot that Canada can do in order to make sure that the right things are talked about, the right agenda is being mentioned, that global health is mentioned as an important topic in some of these larger global conversations, and also making sure that we're bringing in the right players into these conversations. So going back to the decolonizing component to it, are we making sure that when we have these conversations, when we are thinking about reforming the global health architecture and the coordination piece, are the right players in that room? And if not, how can we make sure that the right players are there? So it starts small, I think, but it's quite powerful, because as Kelly said, we're in a really critical moment right now where there is a lot of opportunity for us to reform and reimagine and redefine what global health can look like. And in order for us to be successful on that front, we need to make sure that we don't just continue the same path where it's very donor funded, donor focused as we have in the past, and make sure that it's much more equity focused, both in terms of theory, but also in terms of practice.
Could I just jump in, Pete, and just follow up on a point that you made? This whole financing issue is something that's really critical to the I guess reimagining of global health. We cannot fund the global health architecture with voluntary contributions. We're essentially doing that. We're passing the hat around every year, every other year, and we're expecting countries to step up, and they decide. These organizations cannot have strategic planning ahead, because they never know how much money they're going to get, right? And suddenly we've had a big shock. We wouldn't fund our core public services in our countries that way. We use taxation. And so there has to be a much different financing model. And I know the Lusaka Declaration has set out some of these. Others have done so. Innovative financing mechanisms have been talked about a lot over the decades. I would say for Canada, we have a new Prime Minister who I respect very much as someone who has a brilliant mind about financing. I put it to him. He may have some ideas about how do we finance the global health system in a way that is sustainable, that it gets buy-in from people, and that we get value for money. And I think he's, if anyone, probably has the ideas to do that. So hopefully this is maybe a way that Canada can move forward.
Fantastic. I sort of slightly wish that was the last question, because then that was a very nice note to finish on, Kelly. But we have time, and I'd like to go into one more topic, if that's okay, which is thinking more whole of government, I guess. Like, what else can Canada do? Think about trade policies. We sort of touched on migration policies, but there could be more there. Thinking about intellectual property and research and development. What else could Canada be doing to be improving the health of the world? Who wants to take that first?
Well, I work around. I've been focusing a lot on pandemic response, preparedness, future readiness. And one of the lessons, of course, is that we know that the pandemic hit societies as a whole. It wasn't just a health issue. It really impacted economies and societies. And what we learned from that is we need to embed health in a much broader policy framework. And so there's been a lot of efforts to not only define, health and all policies, or whatever we describe it, but also think about these issues in a more holistic way, which is why we put forward that One Health Security concept as something that really isn't just about, investing in vaccines, which is incredibly important, and in other pharmaceutical interventions, incredibly important. But that's only the starting point. We need to think about primary prevention. How do we organize our agricultural systems? How do we deal with climate change and the sort of very upstream aspects of pandemic prevention? And so if we can't do that, then we're always going to be responding. We're always going to be reacting, and often, insufficiently, because we're not thinking about the whole picture. And so thinking, I guess, rethinking from a holistic point of view, how do we prepare our societies for these kind of events in a holistic way would be an important starting point.
I'd just like to add to Kelly's point, and I also work in the pandemic space. So I think something that I'm thinking about quite a bit is how do we invest between crises, right? I feel like we're constantly reacting to crises, and that space between crises is starting to become shorter and shorter. But I'm thinking a lot about, it's a buzzword, but I think there is some validity to it, the concept of having resilience when it comes to pandemic prevention, but also emergency readiness more broadly. And so what does that look like in terms of investing between crises? Does that mean investing in our workforce? This was something that we highlighted quite a bit in the report. Does that mean having sustained surveillance systems that can catch diseases and threats that are local, that are fast, that are adaptable? The trust component and the communications component that Kelly mentioned earlier, how do we ensure that we build trust or rebuild trust in our science and our scientific institutions? So I think there's a lot of core capacity building that we need to do to invest between crises so that when global health crises, global health emergencies occur, we're not struggling and starting from scratch every single time.
Yeah. It continued to be hard to actually get funding for some work in pandemic preparedness at the moment, which seems remarkable, doesn't it?
Yeah.
Robert, any comments to add to that?
No, I think those points are absolutely right. I think there's the broader challenge of rebuilding our faith in government and the ability of having democracies that can deliver, and the health challenge is part of that. But certainly the pandemic just underlined how important it is to have governments that can deliver effectively, and that to have societies that can trust those governments. And I think that includes in health, but goes beyond it. And that's certainly something where, again, Canada working with other, particularly democratic governments around the world, have an opportunity and a challenge to kind of rebuild that confidence with citizens and demonstrate that governments can really deliver effectively in this space.
Yes, absolutely. Now have so many benefits across the public sector. I've got a question in from the audience saying if we essentially use the narrative of global health 2.0 or perhaps health as mutually beneficial to all, might we actually unintentionally overemphasize some of the areas that benefit Canada or things like global health security that benefit everyone, and may we neglect some of the things that don't benefit Canada but that actually benefit some of the most vulnerable people in the world?
That was always the risk. Yes, that's always the risk. And I guess our report reflects a moment in time when we're navigating a very politically challenging time coming out of a pandemic, but also, having partisan politics at play. And at the time we finished this report, we weren't sure which government we were getting, it has to be said, which party was going to be in power. And so we had to kind of recognize that there was a risk of withdrawal of investment in global health. And I think we are more divided than I think we'd like to think in Canada. So that was always the risk. But my sense is that if we can invest in the things that actually are mutually beneficial, people feel more trust again, and that rebuilds that kind of understanding of what global health is. So there's a route back. I mean, I think what we're doing now is trying to rebuild, and certainly we didn't want to forget those areas where Canada doesn't have an interest, but it's more of a pragmatic approach that we're taking.
Interesting. Well, but I saw you jump in at the beginning then, Lisa.
Well, so I think it's a legitimate concern, but there's so many places where there's mutual interest. Obviously, the issue of infectious diseases is one, and really addressing tuberculosis around the world could help us address the crisis of tuberculosis in our northern communities. But there's also areas of applied learning. So if we can get better in helping rural and remote communities around the world, that can also help us support rural and remote communities with new technologies or task shifting here in Canada. and even breakthroughs in terms of health systems or new drugs. That if we take the example of the Ozempics and so on to deal with the NCD crisis around the world, if we could be involved in supporting breakthroughs that can help citizens around the world, I think we can make the direct argument that it also benefits Canadians at home. So I think we need to be sensitive to this, but I actually think health is such a great example of it being a positive sum game if done right, if communicated effectively. And frankly, there are so many issues that are underfunded where there is such a direct element. I actually am not too concerned in practice about the implications of that kind of an argument.
Yeah, I definitely see that logic. I guess I also see the logic of if we're trying to take a new version of doing global health where we empower, for instance, LMIC decision makers to set their own priorities, and yet we say that the top priorities are global or truly global. There seems to be a tension in that to me. That is not, I feel like if you speak to most African ministers of health, they will not say my top priority is pandemic preparedness. And you've got a bit of a tension there with global health 2.0. But Prativa, do you want to reflect on that?
That's true.
No, I mean, that's a really, really great point. And I think goes back to what we were saying. A lot of these decisions and a lot of these priorities have to be conversed as a group, right? I mean, all three of us in this panel, we are from Canada, we are from a higher income country. So I think it would have been helpful to have someone else come in to talk about this from their perspective. I will say, though, that while we were sensitive to that tension, I think it still is a strategic decision from Canada's perspective. Something that I've been thinking quite a bit about is the invisible successes problem, right? So when global health is successful or when public health is successful, the bad thing doesn't happen. And so how do we communicate that to folks, to taxpayers, to say, well, your dollars invested prevented this from happening when that bad thing didn't happen? So did you overreact to the pandemic, for example? And I think so, given that type of thinking that we're seeing, it is a strategic decision to say, well, if there is that mutual reciprocity here, then you can see how their investments or how our investments are leading to mutual benefits to everyone involved. So that's very much from Canada's perspective, but I'd be keen to hear from other perspectives to see what that would look like.
Thanks, Prativa. That's a good point to end on. I'm afraid we've run out of time. I want to thank you all, Prativa, Kelly, Robert. It's been a fascinating conversation. I think we've heard lots of strengths and weaknesses of the history of Canada's involvement in global health, but also an exciting opportunity with the Carney government, with bipartisan support, but also with the colonial history that provides some kind of lived experience in Canada of some of the challenges that need solving. Hopefully this can contribute in the future to a positive and constructive contribution from Canada in global health. So thank you to all, and thank you to everyone online for joining.
Thanks very much.